Hello, my name is Dr. Verlage, and I am a perinatal psychiatrist. Bear with me as I get this set up. Yes, I'm a perinatal psychiatrist. I help with the MT-PAL line, which is the consult line for providers who need help assisting with their patients who are pregnant or postpartum and their medication management for any psychiatric issues. And as part of that program, I was asked to come up with a series of presentations to help us understand a lot of the issues that these women face, treatment, modalities. And I thought this would be a good place to start off, is kind of understanding the prevalence, the frequency of these conditions in this population as we kind of move forward through this series to understand treatment. Good platform to have an understanding of how common it is. So, obviously, maternal mental health is very, very important. Everybody's mental health is important, but in pregnancy and postpartum, we're thinking of two little lives. So the importance is doubled, if you will. So there's a lot that happens when someone becomes pregnant. There's a lot of, many times excitement, which is great. Many times 50% of pregnancies are unplanned. So you can imagine that there can be a lot of mixed emotions, and women are going through a hormonal change, physical changes, financial changes, existential changes. So there is a whole lot happening in someone's world when they're going through pregnancy. A lot of emotional challenges specifically related to the things I mentioned before. So jumping from that, there is a lot of common misconceptions about pregnancy. So, we talk about a pregnancy glow, and there's it's a time of peace and serenity, and that is so wonderful when it happens. But our studies show that that is not always the case. And for, women who expect that, or society who expects that of women who are pregnant, it can be very isolating to not feel that way when that's the precedent. So it makes me think of a patient case where, this woman who had anxiety became pregnant, and it triggered a lot of anxiety, worrying about losing the pregnancy, worrying about the finances of everything, things like that. And, her husband had found it challenging to say, but, we were trying for this pregnancy. This is what we wanted. How could you see this as a negative thing? And so, that lack of understanding, I think, is not uncommon for patients. So just kind of thinking what they're having to go through day in and day out, especially when these symptoms are exacerbated for all those biological and other reasons. Us validating that when we talk to patients is really important. In this patient, she said, it's because I care so much. It's because I'm so looking forward to this and excited that I'm really struggling with my anxiety. So again, that's thinking of misconceptions. That was a recent case that was came to mind, and really, paints a picture for us thinking about all these things we're about to talk about. So depression during pregnancy, not uncommon. 10 to 15% of women will experience clinically significant symptoms, depressive symptoms during pregnancy. And not surprisingly, women who've had a history of major depression are at higher risk for depression during pregnancy. They are at higher risk for their lifetime, but particularly during pregnancy. Yeah. So to kind of show that or elucidate that, they did a study where of 2,000 pregnant women, they used a scale that was trying to look for risk factors for depression, women who were, again, at risk or currently having depression. And they showed that, and they kind of drew the line at 16 of this scale of where they would call somebody being at high risk. And those high risk things included having depressive symptoms, maybe not a depressive episode, but symptoms, and having used an antidepressant in the past time. So, which were just some of the criteria. So, of the, there was a clear lack of treatment for those women who were at risk and were depressed. So only 20% of pregnant women who were at high risk for depression received any kind of treatment. And treatment can include medications, but it can include therapy, monitoring. So these high-risk women, most of them, 80%, did not receive anything. And then even those who were currently depressed, met criteria for a depressive episode, only a third received treatment. And only 11%, so even less, 1 out of 10 received adequate treatment with an antidepressant medication, which is just shocking. Like, that is so low. We're going to go through some more numbers here, but it is a little jarring to look at these numbers. So amongst those receiving treatment, again, that's 33% total. About half of those received a combination of both therapy and medication, which is, in our minds, ideal. We know that from other studies outside of pregnancy, best outcomes for treatment of depression is a combination of therapy and medications. But for the rest, 20% got only antidepressants and 30% got therapy alone. And sadly, which this slide and the next slide will show, even those that received either treatment, most of them didn't receive adequate treatment. So of the ones receiving medications, 43% of those taking antidepressant actually received adequate treatment, meaning that they started a medication, they were able to stay on it for 6 weeks. That does require monitoring the patient, making sure they're tolerating the medication, making sure you're answering questions, making sure you're educating them that they need to take this medication every day. So we lost half of them in that, which can be for a number of reasons. But and then this slide talks about how the therapy group didn't receive adequate treatment. So when we look at therapy in studies, it's weekly for an hour. That's where we see that this improvement, when we use this intervention, that that it works or helps. In this study, they found that the women who were engaging in therapy had 2 sessions in 3 months, much less than the standard. So we start with a group of women and we chip who are either depressed or at risk of depression, and we've chipped away at very, very small amounts, getting what we would consider, good, adequate treatment. And that leaves a very large chunk of people who are suffering unnecessarily through their pregnancy. So what were the things that, seemed to predict that a woman would receive treatment? So having a history of major depression before conception, they're probably more familiar with the mental health field. They know how to look for help, engage with help, which also fits in with a history of psychiatric treatment. Greater depression severity seem to correlate too. No surprises there. If it's to the point, if it's debilitating enough that we would consider it severe, it would be more obvious maybe to friends and family that they need to have them get help, or a person themselves, it becomes more obvious that they need help. Tragically and sadly, a current episode of depression did not predict the use of treatment. So, yeah, again, lots of women going through it who we are not treating, and that we have plenty of treatments available to help them. And if being depressed before predicted that they would be able to find treatment, then we're thinking that a big chunk of these are women having depression for the first time, with the with the expectation of this being positive. And why would you be sad during pregnancy? And all of these people talking about this. So, so here they are hearing that, not feeling like themselves, grappling all that comes with pregnancy. I could imagine, extremely isolating. They must feel extremely alone. And yeah, we really need to help them. So that kind of paints the picture of what we're seeing during pregnancy. We need to do better. So let's think about postpartum mood disturbances. So once baby's born, any kind of mood disturbance is not uncommon. So 85% of women will experience something in the postpartum period. Now, these can range from very mild and short-lived, but to more significant depressive disturbances or mood disturbances, which we'll describe in a little more detail here. So there's postpartum blues. 50 to 85% of women will experience the blues, and this is usually within the first weeks after delivery. These symptoms can include things like mood lability. They get really happy to really sad, kind of quickly, kind of surprisingly, which kind of fits in with tearfulness, feeling anxious, feeling irritable. And usually these will peak in the 4th or 5th day and resolve within 2 weeks without treatment. So, as it implies, without treatment, these things will go away. And as we can kind of tell from how it's described, it's not impairing their life significantly. So I remember on the consult service in the hospital, there were plenty of times we'd get consults for patients who, were crying. And, do we need to run in with medications? No. Ask them how they're doing in a little more detail. Think about these timelines of how they're doing. And we definitely don't want to pathologize some mood lability that we would anticipate in most women postpartum. So that's the blues. And then we have postpartum depression. So the timeline is that most cases will happen within the first 2 to 3 months, but they really can happen anytime after delivery. A lot of the newer treatments that are specific for postpartum depression will put it up to a year after delivery that we can consider them, again, to have postpartum depression. The hormonal fluctuations that happen during pregnancy happen for 9 months, and sometimes it will often take 9 months plus to reset itself. And we think that hormones play a big role in postpartum depression. So what does it look like? It looks like clinical depression. And it is, again, how the sources that I use describe it. It's indistinguishable from depression at other times of life. So what does this look like? What does a clinically depressive episode look like? Low mood, that one's pretty obvious, but tearfulness, loss of interest in doing things they normally enjoy, negative self-talk where they feel guilty and worthless, fatigue, a sleep disturbance, changes in appetite, be it a higher appetite or lower, difficulty concentrating, and sometimes suicidal thoughts. Anxiety loves to hold hands with depression and is often there too. which we know for any person experience a depressive episode, anxiety is something that needs to be screened for because it can, again, so often go hand in hand. So how do we identify postpartum depression? In the postpartum period, women are going to be sleeping less because they're up with a newborn. They're going to feel tired because they're taking care of a newborn. So we have this specific scale that phrases questions in a way for us to better identify depression with all of these other factors to consider when women are postpartum. So it's called the Edinburgh Postnatal Depression Scale, and most OBs, I would hope, do use them in their clinics, or again, we're moving towards that or trying for that. So they cut it off at 12 or higher, or any kind of suicidal thoughts. Somebody needs to get an evaluation. So, postpartum psychosis, very rare, 1 to 2 in 1,000 women. So not very common. When we see it, it happens very quickly and usually soon after, days after delivery, and almost always within the first 2 weeks postpartum. What does it look like? So psychosis by definition must include either hallucinations or delusions, or, Along with that, you can see restlessness, irritability, insomnia, rapidly shifting mood, being disoriented and confused, and disorganized behavior. And risk of infanticide and suicide is significant. I think I cannot emphasize this enough. Again, it's very rare, but when it happens, we have a very, very low bar to hospitalize women. We don't wait to see if they improve. It is so common for these, as it's kind of written in the slide, delusions will often be centered around the infant and can put the infant in some very serious risk. We do not take separating mom and baby lightly. And so, but this is one place where we really don't risk anything. So any signs of psychosis that are new in the postpartum period should be treated in the hospital. Even if they don't seem dangerous at the time, they can quickly become so. So important for us to at least know about and recognize so that we know exactly what to do, which is not try to figure things out from home and in outpatient visits, but needs to be figured out and treated in the hospital. So I know that was a little heavy, but on a maybe not as dangerous side of things, we mentioned before how depression and anxiety often hand in hand. So postpartum anxiety is something that maybe hasn't received as much as attention as postpartum depression, but is alive and well and happens very often. I don't think I've ever talked to a patient who's had postpartum anxiety that doesn't mention like, oh, I didn't know this was a thing. I thought it was all postpartum depression. So also very much a thing. And something we need to screen for. Here we do, I think, a better job of screening for postpartum depression. I think anxiety scales need to be there too. We all need to be watching for it because we might miss patients who need care because we only ask them if they're depressed. Another interesting one is OCD in the postpartum period. I remember back when I was in a lecture with an OCD specialist who talked about how and again, can't reference this because I can't remember off the top of my head where this person referenced this from, but 50% of adult OCD is diagnosed in the postpartum period. For whatever reason, the hormones and combination of things going on will bring out OCD symptoms. So there are possible subclinical obsessions and compulsions. Again, subclinical meaning that they're there, but they're not. The biggest thing that we use when we diagnose things is it impairing somebody's functioning in life? So if there are any kind of obsessions and compulsions that are not interfering with someone's life, we would consider them subclinical. And if they happen, we don't necessarily need to treat them. Therapy might be nice, because I can imagine they're at least bothersome. But the common themes for these OCD thoughts, aggression and contamination. When they say aggression, a lot of times women will have these intrusive thoughts of hurting their baby, and it makes them very uncomfortable to talk about. And they don't know the mental health field, so they don't know that kind of sharing these intrusive thoughts, if someone's going to take their baby from them, which we know with OCD, these are ego dystonic and they have no intention of acting on them. And they're not at risk of acting on them. So, but you can imagine that a mom with her first baby having intrusive thoughts of hurting their baby is one of the worst things I can imagine. So yes, I would say that is not an uncommon theme for OCD, and sometimes women will be very guarded about it. So knowing the information and knowing how to ask and what to ask is important when we're screening for it. Contamination, a lot of times they're a little more upfront with. So as with everything with psychiatry, women with OCD symptoms are more likely to screen positive for depression too. So, lots of symptoms, lots of things that we have to juggle when we're trying to make sure that these women are comfortable. This slide kind of just harps on what I've been talking about throughout the presentation, which is all of these things overlap. Depression, anxiety, OCD. If you have one, you're more likely to have the other one. So we really need to screen for all of these things. And this last bullet point, just elucidating that a lot of times our goals with depression and anxiety is a complete resolution of symptoms. OCD will usually linger. This is for postpartum or just in general. We don't want to chase with medications completely getting rid of all obsessions and compulsions, but we want people to be comfortable and not have it feel like they are functioning well, despite having some small level of these symptoms. So last slide, we really need to come up with some ways to detect and treat these conditions. So many women are going without treatment, without, struggling, feeling isolated, not knowing what to do, not knowing where to go. And we really need to do everything we can to get them the care they need. Adequate care, not just any care. So screening, that Edinburgh scale, great. We need to have that scale along with anxiety and OCD scales and OB offices. And we need to figure out a way to streamline getting these women into treatment quickly. We can't have these 5-month wait lists where they'll have to struggle throughout their pregnancy without care. I know these are all much easier said than done, but I know everybody who's going to be watching this is going to agree with me. And even talking about this and reading through these articles that I used to make these slides, it's, very motivating to really do everything we can to help them. So on that note, I'll be coming out with more videos with similar topics. This is a good place to start. We can all agree that we need to do everything we can. And I hope you have a lovely day. Let me know. You can write me or get a hold of me if there are any questions. Thanks.